Okay, Assalamu alaikum wa rahmatullah. Welcome back, everyone. This is Noura Safyani speaking to you and would like to welcome you to our seventh session of our symposium, where we'll be talking all about neurology. My co-chairperson will be Dr. Ashwaq Al-Ruwaili. Our first esteemed speaker is Wafa Al-Gahtani. She's an MRI technologist who works in medical imaging department of King Saud Medical City, experience in clinical practice. She graduated with a master's degree in radiological sciences and magnetic resonance imaging from the College of Applied Sciences in King Saud University. Her professional interests include MRI technology development, patient-centered protocols, and improving diagnostic accuracy through advanced MRI methods. Today, she's talking to us about magnetic resonance elastography in evaluating spinal cord elasticity. I'd like to let everyone know that Wafa Al-Gahtani will not be joining us for breakout rooms. So if you have any question and answer, please type it in the chat. And if we have time, we will pull up some of these questions. Wafa, please go ahead and start.
Hello everyone. Thank you, Professor Noura and Professor Ashwaq Al-Ruwaili for the introducing. Am I clear? Is it clear for
Yes,
everyone?
your voice is clear, but I don't see your presentation. You're not sharing your screen? Yes, perfect.
Okay, hello everyone. Inshallah, I will talk about using MRE in evaluating spinal cord elasticity. In the era of technology, portable devices have become increasingly reliable and useful because they contain all means of communication, entertainment, and more. Spending a lot of time using electronic devices will result in prolonged neck flexion and leads to tick neck syndrome. Untreated conditions may lead to permanent damage of the spinal cord, such as flattening of the spinal curvature, spinal cord degeneration, decompression, and herniation. According to a study by the Journal of Physical Therapy Science, 68% of young adults report experiencing neck pain linked to device use. Bending our head forward at a 45-degree angle to look down and forward to the mobile or tablet can increase the chance of having what is called tick neck. You can imagine that by carrying a gallon of milk and extend your arm to understand the pressure on your neck, shoulder, and back. The head is weighed 10 to 12 pounds, so this may cause a neck muscle to strain, shoulder to slump down, and the pressure on the nerves. The World Health Organization projects that the global population aged over 60 will increase from 11% in 2010 to 22% by 2050, an epidemiological shift that marks the transition from infectious disease to chronic degenerative condition. Using mobile is not the only cause that cause this problem, but it's one of the most reasons to increase statistics in our era. So, with the increased prevalence of degenerative disease, the demand for a reliable clinical approach for the quantification of the mechanical properties of the spinal cord is essential. We are doing that by using magnetic resonance elastography, which is different from using MRI. Why is quantifying spinal cord stiffness clinically important in degenerative disease? We think that assessing spinal cord stiffness by MRE may aid physicians in the early detection of critical stenosis and also help identify patients who require urgent surgical intervention. The aim of this study is to estimate the shear stiffness of the spinal cord at the cervical spine area for healthy volunteer, as this not done before, and also to investigate how the shear stiffness will change in the presence of the stenosis for patient with degenerative disease. So here we study 57 subjects in where 24 of them are healthy control, while the rest of them have stenosis at different level caused by the prognosis of degenerative disease. To classify and understand our cases, we follow what is called a grading system. I include the link here below. So this system classify patient based on the stenosis degree. As it's showing here, grade 0 mean that no central canal stenosis at all. Grade 1 for patient who have partial absence or obliteration of anterior or posterior subarachnoid space. Grade 2 for patients who have either complete absence of anterior or posterior CSF and cord deformity. Grade 3 for patients with the signal change on the spinal cord. Unfortunately, our cases only include only one patient with grade 3 stenosis, so we think it's too early to jump to any conclusion. We go further and classify these patients of grade 2 into 2A and 2B. As it's shown here, patients who have 2A have only cord deformity without an absence or complete absence of CSF, and grade 2B for patients who have both cord deformity and complete absence of CSF. So in our method, we try to draw the ROI in many times, and this is the final ROI that we conclude at the level of the intervertebral disc. And we draw it at three area, proximal to the stenosis and at the stenotic region and distal, to ensure the consistency of the results and to avoid interference with adjacent structure and avoid overlapping with other ROI. So we follow the method or steps of doing MRE, starting by tissue excitation and then MRE imaging. After that, processing the data. For that, we use MRE Lab, which is a research software platform used for data processing and analysis. This software can be used for processing phase image, estimating mechanical properties of tissue, and also for performing wave imaging and filtering. So as this video show here, you can see how the wave propagates through the spinal cord. Here you can notice in some point that the wave pass horizontally. So these are the image that we selected for calculation. And then after that, we follow the manual process that is called wavelength estimation for calculation by counting the number of pixels and then insert it to Helmholtz equation. So in control, we found that the upper cervical region is distinct in its characteristic from the lower cervical region. If we study each IVD individually. So level is more mechanically constrained, less mobile, and also subjected to higher loads. We found that always C2 less stiff compared to C4, C5, and C6. By running two key tests, as it's showing here, each bar represent a pairwise for cervical level comparison, we can see here that in a comparison among C4, 5, and 6, indicating similar stiffness at lower cervical levels. Also, we can notice that no pairwise comparison is statistically significant after two key correction, and this is fine because we are studying here uh, a healthy volunteer. In a patient with stenosis, we found that patients who have grade 1 and 2A sometimes act like grade 0, so it's like there is no stenosis at all, while in other patients, it came with low stiffness value. In stenotic region, for patients who have grade 2B, it's always came with less stiffness value compared to the surrounding region. So what is the meaning of low stiff? It means that there is a loss of normal tissue integrity and mechanical function. The lowest stiffness value found in patients with stenosis who have grade 2B. So by comparing the area of the stenosis and the proximal, we can find that the p-value is equal 6 times 10 to the minus 5. And by comparing distal and stenotic region, p-value equal uh, 2 times 10 to the minus 3. So after that, we taking T5 as an index level for comparison between control and patient with stenosis. We found that C5 on control is stiffer than patient with stenosis. Why we decide to take C5? Because spondylitic also mostly occur in C5. So we take it as an index level. So in summary, we can say that stenotic region is with low stiffness value compared to surrounding region and healthy one at the same level. The lowest stiffness values found in patients with stenosis who have grade 2B, but in general, we cannot say as the stenosis increase, stiffness decrease until we study the grade 3. The upper cervical region is distinct in its characteristic from the lower cervical region if we study each IBD individually. So thank you for listening. I would like to express my sincere thanks and appreciation to the organizer of this symposium for their excellent efforts in planning and hosting these events. Thank you all.
Thank you so much for your presentation, Wafa. This was very interesting. Do we have any questions from the audience or the chairpersons or hosts?
السلام عليكم دكتورة نورة.
وعليكم السلام. تفضلي.
If there's no questions, may I ask a question?
Please go ahead.
شكرا دكتورة وفاء على المحاضرة و very interesting correlation between computational techniques and medicine. What I'd like to ask, please, is about the clinical implications of your work. So you said that stiffness is not directly correlated with stenosis. What does that mean clinically? I mean, when you say stiffness, do you mean just the numerical values that indicate stiffness as defined in your computational technique? Or do you mean the clinical feeling that a patient feels their neck is stiff?
Yes, okay, doctor. We didn't try to go to any conclusion until we study grade 3 stenosis. So because of that, we cannot see in general that as the stenosis increase, the stiffness decrease. And this came as opposite of what we find by studying the same patient with ultrasound. So the stenotic region came with a high stiffness value. So we try to figure this out as this is the first time to study spinal cord by MRE.
Okay, very interesting. We hope to host your future follow-up work, inshallah, in the upcoming years.
Thank you, Professor.
Inshallah. We have a question here in the Q&A. The question says, what is the name of the data set used and from where it was taken?
It's taken from King Khalid. Again, Doctor, what's the question? From where we take the data and also?
What's the name of the data set?
From DICOM, we can explore this image as DICOM and then use the magnitude, phase, and sagittal T2 of the cervical spine to study it in MRE lab.
Okay, hope this answers the question. Prof. Asma, did you want to answer something? Okay.
No.
Okay. All right. Thank you so much, Dr. Wafa. Much appreciated. I would like to move then to our next speaker, who is Prof. Sayed Shahid Habib. He is a professor of physiology and consultant in clinical neurophysiology in Khalid University Hospital. His main contributions have been to study neurocognitive functions, cardiovascular risk markers in obesity and type 2 diabetes. At present, he is keenly interested in studying non-traditional cardiovascular risk markers, heart rate variability, neurocognitive functions, and adipokines in different metabolic diseases. He published numerous research papers in international journals, received many research grants from King Abdulaziz City for Science and Technology, and Deanship of Scientific Research. We are very honored to have you, Professor Sayed, and the mic is all yours. And we will be glad if you can share your screen with us.
Thank you very much. Bismillahirrahmanirrahim. I hope everybody can see the screen now.
We can see it, but if you can switch to the presentation mode, yes, perfect.
Yeah, it's okay now.
Yes.
Bismillahirrahmanirrahim. I am thankful to the organizing committee for giving me a chance to talk on this topic. And the title of my talk is Clinical Utility of EEG Interpretation in the Era of AI, the Road to Reliable Neurodiagnostics. There is no conflict of interest to declare. So the outlines of my presentations are going to be that what are the key phases in the AI journey in EEG advanced technology. Also, I would be talking about the enduring role of EEG in neurology and some key challenges in its interpretation, and why the challenges have a diversity and they are huge because of abnormalities that mimic the non-epileptiform discharges, bridging the gap between computational power and clinical reasoning, and EEG-related AI systems and software for epilepsy detection. And then how can we integrate the AI as a reliable partner in EEG review and some conclusions. So let me give you something amazing about the brain. Human brain is made up of around 86 billion neurons, and we have around 500 trillion synapses in our brain. And also we generate around 70,000 thoughts per day, and more than 99% of these thoughts are filtered. The human brain has a capacity of 2.5 petabytes, which is equivalent to 2.5 million gigabytes. And there is a special characteristic of the human brain that the common notion, use it or lose it. Daily, if we remain inactive and we don't utilize our learning capabilities, we are going to lose 85,000 neurons per day. So if you want to save them, you have to go through brain exercises regularly. And coming to our main topic, that EEG is the summation of synchronized excitatory and inhibitory postsynaptic potentials from millions of cortical pyramidal neurons. And this is what we are going to discuss now. Let me start with a very short case scenario that when EEG meets AI, a surgical choice in drug-resistant focal epilepsy. So I just present a scenario of a 46-year-old male with drug-resistant focal seizures. He had normal routine EEG, but when he went to EMU, that is Epilepsy Monitoring Unit, and that was analyzed by AutoScore, the AI system, it detected some localized seizures. And MRI confirmed the nature of the tumor, and he was advised surgical removal. So if he has option that whether he would go for a highly expert neurosurgeon or an AI-driven robotic system, so what is going to be the most likely choice for this patient? What he's going to choose. So just keep this scenario in your mind and we will proceed further. The key phases in the AI journey, they started from traditional machine learning technique, and in the decade that passed, it went into the depths of deep learning. And then the revolution came, which is known as the transformer revolution, in which the large language models started to develop. And then in 2020s, generative AI came, that we start understanding the data and then creating models for it. And now we are moving to the future prospects of AI agents, in which we are going to make decisions and take actions rather than just diagnostic part. Myself, I'm not an AI expert, but I learned and we are using some AI techniques in our clinical practice, which I'm going to share. So as we are moving from original to AI, the original intelligence refers to human intelligence, often described as genuine organic consciousness and cognitive capability. So if we compare it to the AI, the technology that enables machines to emulate human cognitive functions. Moreover, humans create, innovate, and generate truly novel ideas, while the AI produces outputs based on patterns in existing training data. Now, if we are comparing both, we have few things to consider in our mind, that whether they are going to benefit us in terms of reducing our time that we give to the work or that specific task. At the same time, we are concerned with the accuracy. Thirdly, reproducibility, that if I give the same task again and again, it should give me in time, accurate, reproducible results. Effort should be reduced, the burden should be reduced. I should have resources available. Manpower also at the front end and at the back end is needed to reach out every patient, every case, everywhere. This is our target. Financial burden should be considered at the same time, because some of these softwares are very expensive. And the output that it gives us should make a gross benefit or change. So let's see how we are proceeding in our clinical practice with EEG. The facts are that EEG is the most time-consuming diagnostic test in clinical neurophysiology, okay? Especially when it comes to the LTM, long-term monitoring, which may take around 7, 8, or up to 10 days sometime, or even it can go up to 2 weeks. At the same time, EEG is the most low-yield test in neurophysiology. And around 2/3 of the cases who have epilepsy, they will have normal routine EEG recording without any abnormality. Also, EEG is frequently cited as one of the most complex and the most confusing diagnostic test for many, many reasons. But at the same time, the key strength of EEG is its unparalleled temporal resolution, that in real-time manner, it can give you the dynamic neural processes happening at each millisecond. And despite the new imaging modalities, EEG remains a cornerstone for assessing functional brain states and epilepsy management. So the challenges that we are facing now in the manual EEG review, that it needs a high cognitive demand and time. At the same time, the EEG is susceptible to many artifacts. The patient and interscorer variability, and the workload that creates backlogs and delays in reporting. So we need some more measures to save all these or to overcome these challenges. So the challenges that we are facing are the artifacts and the variability, high cognitive demand, interpatient variability, time consumption, interscorer variability. So human trust and satisfaction at the same time is also required, that we trust it. So how to move to that level of trust by the auto scoring or by the AI technology. And we know that misdiagnosis rates in epilepsy are often linked to variability in how different experts report the same data. And why is that? Because the epileptiform abnormalities have a great diversity. And these are some of the common abnormalities like spike, sharp wave, polyspike, spikes and waves. And you have to clearly differentiate them from the non-epileptiform discharges. So if you see here, these are spikes, sharp waves, spike and wave, sharp and slow wave combinations, slow spike and wave, polyspike, multiple sharp and slow waves, polyspikes, and then we have complexes. So to define them, we need to know their exact morphology, location, age, state of awareness of the patient, artifacts, and any physiologic state that will mimic these. Because we know that number of seizure and epilepsy types, there are more than 25. And we have around 50 epilepsy syndromes known. And overall, there are more than 100 epilepsy and seizure disorders that are reported in medical literature. Also, we need to consider some common normal variants. And up till now, more than 30 common normal variants have been reported. And they all mimic the epileptiform discharges. Some examples are Muridum. If you look at the lambda waves, vortex waves in sleep, posts. Yeah, there are eye-opening artifacts. Then we can have wicket waves. We can have rhythmic mid-temporal theta activity. We can have eye movement artifacts. We can have alpha squeak. We can have breach artifacts. All these will contaminate, or they are related to your EEG recording, small sharp spikes, and they are normal variants. At the same time, you should have a very clean record, which is free of artifacts, both physiological, which are patient-related, non-physiological, which are machine-related. And so far, we know that more than 50 artifacts have been defined, and they are contaminating the record. You can see these all. You see here, these are EMG artifacts. This is movement artifact. If the patient moves, this is tongue artifact. Even if he moves his tongue during a record, yeah, these are slow oscillations because of sweating. There can be artifacts due to tremor. These are the artifacts due to muscle. These are artifacts due to electrocardiogram, pulse artifacts. So just to give you an overview, the current artifacts it can give you the eye movement artifacts. So there are a lot of artifacts. So what is needed now, that now we are moving from the traditional manual EEG review to machine learning, and then a step forward towards deep learning, the auto scoring system, which I'm going to present now. And when we were reporting manually, the traditional machine learning came. And in traditional machine learning, what we are doing, we are feeding the data into the system, and it gives us that whether it's normal or abnormal. And the one which is still we are using is Excel Tech NeuroWorks, but it has a lot of limitations, and it will mark any artifact as a epileptiform wave. So we are in the need of a system which is mostly not related to the patient abnormality, the artifacts, variants, consider all factors, and the deep learning technology that is going to filter out all these things. So it's quite powerful, and that is which is now available is as AutoScore by the Natus company. So the challenges of manual EEG review, which is high cognitive demand, interpretation variability, creating clinical blogs, has been solved by the AI scoring. And this AutoScore AI is 50 times faster for review, and it overrides the human performance sometime. That is, the human expert will give you a maximum of 83% performance, and the performance related to AI has been claimed by the AutoScore Natus company, published in JAMA, to be 88%, with a sensitivity of 87% and specificity of 90%. There are other softwares available also apart from AutoScore: Insivis, SpikeNet, Persist, EpiHunter, MELT, and all these are related to specific tasks, like for home use, for smartphone applications, relationship with the MRIs, and many things. What I'm going to discuss today is the Natus NeuroWork AutoScore system, which has been published in JAMA. It is the world's first AI-based model that provides comprehensive clinical EEG interpretation with performance on par with medical experts, and uses the deep learning technology. And it just gives us a proper answer that can an AI model be trained to interpret routine clinical EEGs with accuracy equivalent to that of human experts? Yes. This is what is claimed by the Natus. And we are in the process of, we have put a proposal to purchase this software. Their data was published in JAMA Neurology in 2023. And what they have done is that around 30,000 EEG recordings were fed into the data analysis system through a deep learning process. And the result was that a comprehensive interpretation in circuitry interpretation model, not just a simple spike detector. So 200 experts reported this data. All these 30,000 EEGs were put into the learning model, and then they created an automated interpretation of clinical electroencephalogram AI diagnostics. So it was found that it shows a 95% of accuracy in distinguishing normal versus abnormal studies. And it provides you with automatic classification also. Not only that it will detect, but it will classify the abnormalities also. And at the same time, it will give you a color coding according to the priority levels also. So it streamlines your work and is more efficient, saves time. And if we go further and analyze, it can classify the categories of epileptiform discharge into focal, generalized, focal non-epileptiform, diffuse non-epileptiform. And probability scoring is around 92%. And you can see the color codes here: abnormality, focal, generalized epilepsy, focal non-epileptic, diffuse non-epileptiform into red, green, light green, and pink colors according to the priority or probability. Also, it gives you detailed marker level analysis that it can navigate, filter, and just jump to the abnormal recordings, especially in the long-term monitoring. The recording is long for up to 7 days, and it can take you to the abnormal parts in the EEG within seconds. And also give you the detailed analysis, the density display. It can segregate the segments of abnormalities. So it's quite useful for long-term monitoring in even routine ambulatory EEG. And you can adjust the safety of the data. Data will stay within the platform. Real-time review is possible. No separate logins. So it has, in summary, 90% specificity, 87 to 89% sensitivity, so which is very high. Overall accuracy is 88%. Human accuracy has been reported to be 83% because there is inter-observer variability in reports. So overall accuracy is 95% in distinguishing normal versus abnormal records, and it is 50 times faster and saves time. And they have also provided a safety, privacy, reliability model also, which is the closed model, and the data remains secure to keep the ethical standards. So, in summary, I would say that EEG is one of the most time-consuming, low-yield, complex, and potentially confusing diagnostic tests to be interpreted for many reasons that were cited in this presentation. Also, manual EEG review has high cognitive demand, artifacts, inter-patient and inter-observer variability, and a lot of workload. AutoScore is the world's first AI-based model that provides comprehensive clinical EEG interpretation with performance on par with medical experts. It's 95%, so it overrides in some aspects. This is what the company says, and they have observed. We are still in the phase of purchasing this software and use in clinical practice so that we can tell you our own experience. AutoScore AI is not validated for uses. It has its limitations. You cannot use them in intensive care units. It's not available for neonatal settings or infants. It's not used for home care still. And it does not detect the epilepsy syndromes. So, and it also has some limitation in detecting those disorders which are related to the imaging but not to the EEG. So it does not have a relationship or a feed-in information of the MRIs, the imaging techniques. Therefore, it detects, but it does not diagnose a problem. It will just detect the epileptiform discharges and classify them. It's not a replacement at all for clinical judgment. So what's the take-home message? The take-home message is that no doubt AI technology saves time, increases output, and accuracy, but we should accept that AI-based reports are meant to support. They are not at all replacement for clinical judgments. Also, the future research should focus on developing hybrid models where there is an AI detection reliable tool, and that is going to be used by experts for verification, because AI may be very good or best in non-human use, but when you are directly using it in human for decisions, the expert verification remains the cornerstone and the gold standard. So let me just go back to the case that we were studying of the focal epilepsy that needs surgical removal of that tumor. No doubt the AI detected the seizures through the autoscore technique, but when it comes to the decision how to operate that tumor, so what should be the most likely choice? So I would say that human in the loop model is the cornerstone, where the human plus machine synergy, the highest trust levels are often found in scenarios where a human doctor uses AI to assist. And that's all from my side. Thank you very much.
Thank you so much, Professor, first of all, for the insightful information and sticking to the time. Thankfully, the professor will be joining us in the breakout rooms at the end of the session. So I'll give the mic to my co-chairperson to introduce the upcoming speakers.
Oh, thank you so much, Professor Noura Sufyani, for guiding us through that segment so smoothly. Minimal Zoom chaos, maximum science. Thank you so much. Well, after a full morning of brilliant presentations, you are officially warmed up and your coffee has earned its keep. Now, let's keep the momentum going with our next two speakers. Ready to keep your neurons firing and your curiosity fully switched on? Okay, so Dr. Sayed Muhammad, inshallah, Doctor of the Future, he's our next presenter. Sayed Muhammad Habib is a fifth-year medical student at Sulaiman Al-Rajhi University in Saudi Arabia with a research track record that is already more seasoned investigator than a student on a caffeine. He's an active member of the American Board of Regenerative Medicine and currently a research intern at a global innovation in Dallas, Texas. Today, Sayed will take us through his talk titled Evaluating Large Language Models in Neuro-Oncology. Sayed, the floor is yours. Take us in.
Thank you very much, Dr. Schwag. I hope my screen is visible.
Yes, it is.
Okay, thank you. Good afternoon, everyone, and thank you for joining this session. My name's Sayed, and I'm here today to present our research on evaluating large language models in neuro-oncology. So this was basically a collaborative study involving researchers from institutions across Germany, Pakistan, and Saudi Arabia, and I'm honored to share our findings with you at this prestigious symposium on computational medicine and AI applications. So let me start by setting the context. We're living in an era of unprecedented artificial intelligence advancement in healthcare. And large language models, or aka LLMs, are AI systems that use natural language processing to understand and generate human language. Now, what makes these tools remarkable is their ability to retrieve and analyze vast amounts of information within seconds. And we're already seeing adoption across various healthcare domains, such as clinical coding, diagnostic support, patient education, and we personally use it a lot to gain research assistance. But the critical question that motivated our research was that can we actually trust these LLMs in high stakes clinical decisions? So this is especially important in fields like neuro-oncology, where the margin of error is it's extremely small. So So why did we choose neuro-oncology specifically? So like I said, well, neuro-oncology represents one of the most complex subspecialties in neurosurgery, and it demands an interdisciplinary approach. So it requires constantly updated knowledge across multiple fields and involves highly complex treatment decision making. So when we reviewed the literature, we found a significant knowledge gap. So there was very limited data on how actually LLMs perform in the settings of neuro-oncology. And so there was limited data on how they actually perform and specifically on their accuracy, reliability, and whether they can be trusted for clinical use. And so this led to our research question that are these readily accessible AI tools that anyone can use on their phone, computer, laptops, or iPads actually are they ready for integration into a neuro-oncology practice? And so what our primary aim was, it was pretty straightforward, was to assess and compare three of the most popular ones and in uro-oncology clinical case scenarios. So we selected three LLMs for evaluation. Now, this study was published in 2025. We carried it out in 2024. So the models were from that time. So we had ChatGPT 3.5, ChatGPT 4 from OpenAI, and we had Gemini Advanced from Google. And these were chosen because they're the most widely used and easily accessible to both clinicians and patients. So we evaluated these tools across three critical parameters. So the first parameter was the accuracy on how correct is the clinical information that they provide. Second was regarding the completeness on how comprehensive are their responses. And third was regarding the usefulness on how clinically applicable are their recommendations, right? So uh, let me just walk you through our methodology real quick. So we conducted a semi-quantitative comparative analysis, and our team consisted of senior neuro-oncologists, and they drew on their years of experience to formulate 20 common neuro-oncology cases. Then these weren't abstract scenarios. We included detailed examination findings, investigation results to mirror real clinical presentations as closely as possible. And for each case, we developed a standardized questionnaire with four essential questions that address the core aspects of any clinical management of any case. So one, what's the differential diagnosis? Two, what diagnostic workup would you recommend? Three, was that what your provisional or accurate diagnosis is or would be? And four, what's the management plan? And so if you look at the flow chart on here, the right-hand side, so what we did was we began by prompting each LLM with the same standardized introduction, asking if it could assist with the diagnosis and management. Then we presented each case individually, asking questions separately to avoid any memory retention bias between responses. So for each case, we had to use a separate tab, separate prompt, and a separate chat. Here's what was crucial. So what we did, we took extensive steps to ensure objectivity, and that's what made this study special, because we have a lot of papers on the subjective assessments of these models. So all responses were replicated into Word documents with identical formatting, and then they were completely blinded so that the senior neuro-oncologists that would evaluate these blinded responses would not know that what was the source or what LLM was used to generate each of the responses. And then we used a common consensus approach for the final grading. And so this helped us ensure that the evaluators were judging the content purely on its merits without any preconceptions about which AI generated it. And So if let me just explain the evaluation scales that we used, because we said that we used an objective assessment. So we had three domains: the accuracy, completeness, and usefulness. So for accuracy, we used a 6-point Likert scale, and this ranged from completely incorrect at 1 through various gradations up to correct at 6. And this granular scale, it helped us and it helped the evaluators to precisely rate the correctness of the clinical information. For completeness, we used a 3-point Likert scale, starting with incomplete if significant parts were missing, adequate if the minimum required information was provided, and comprehensive if additional context beyond expectations was included. And for usefulness, we used another 3-point Likert scale, starting with not useful for incomplete responses, somewhat useful for semi-complete responses, and useful in management for complete actionable answers. And these validated scales have been used in previous medical AI evaluation studies. So they were validated. Um, for the statistical analysis, we used SPSS and R for all of the analyses. We applied descriptive statistics to examine the word and character counts. So that's what we started with, and how verbose each LLM was. And then we used the Shapiro-Wilk test to check the data normality, then ANOVA to compare the performance across all three different LLMs. Then we performed a post hoc test for the pairwise comparisons. And then after that, we applied a Benferroni correction to adjust for multiple testing. And we set up the significance threshold at 0.05, so the p-value of less than 0.05. And our null hypothesis, it was very simple, that the distribution of all our metrics would be the same across all three LLMs, and any significant differences would just tell us that the models really did truly perform differently. So yeah, I think we should dive into the results. So we'll start with a simple the informative metric here. So we started with how much each LLM actually wrote. So we just, as you can see here on the table on the right-hand side, is that ChatGPT 4 generated the longest responses by far. With a mean of 392, Gemini and 3.5 were quite similar, ranging from 280 to 290 words on average. The interesting thing here is the range, because ChatGPT's minimum response was about 177 words, while the maximum reached 495 words. For 3.5, it showed the highest variability with a standard deviation of 95 words. It had a very high standard deviation. And what this actually suggests or suggested was that ChatGPT 4 consistently provided more detailed responses, which could contribute to its completeness scores. And we'll talk about the completeness scores shortly, and we'll compare them on the bar graphs. So let's start with our first domain, which is the accuracy. So for our major finding, accuracy across the different domains, right? So if let's start by looking at panel A. This one's for the differential diagnosis only, and I've included all the charts for the differential diagnosis. So here, if we see the Gemini Advanced actually scored slightly higher at 5.25, followed very closely by ChatGPT 4 at 5.2, and ChatGPT 3.5 at 4.85. And if you take a look at panel B for the diagnostic workup, ChatGPT 4 took the lead at 5.15, followed by Gemini at 5, and ChatGPT 3.5 at 4.9. Panel C showed something interesting. Now here, if you see for accurate diagnosis, ChatGPT 3.5 actually scored the highest at 5.1, and then edging out ChatGPT 4 at 5.05, followed by Gemini at 4.85. And so this was a little unexpected, and we'll discuss why this might be the case. And then if you look at the last panel regarding the management, so it shows the ChatGPT 4 leading at 5, followed by Gemini at 4.85 and ChatGPT 3.5 at 4.75. So if we talk about the overall accuracy, here is the overall accuracy. So when we combine all the domains together, we get this overall picture. So ChatGPT 4 achieved the highest overall mean accuracy of 5.12, followed by Gemini and followed by ChatGPT at 4.9. So the key statistical finding here was that despite these numerical differences, when we ran ANOVA, we found that there were no statistically significant differences between all three models in overall accuracy. So what does this mean clinically speaking? That it tells us that all three LLMs, they demonstrated high accuracy in the nearly all correct range on the Likert scale, and that they're all performing at a level that's clinically acceptable from an accuracy standpoint, with consistent performance across the variety of case types that we provided it with. After this, we can also talk about the completeness analysis. So for the completeness analysis, we can go back here. Yeah. So you can see the completeness analysis on figure 5. And so let's start again with panel A. Gemini scored 2.15, followed by ChatGPT 2.1 and ChatGPT 3.5, with a score dropping to 1.8. And this difference, it was statistically significant. So the completeness here actually told us a complete different story, and the differences here were significant. So let's move on to panel B and C now. Here, you can see that roughly speaking, ChatGPT 4 and Gemini, they perform nearly identically, both providing adequate to comprehensive responses. And 3.5 trails behind, but remains in the adequate range. Last panel shows the same pattern, ChatGPT 4 at 2.0, Gemini at 1.95, and ChatGPT 3.5 at 1.9. Last domain that we assessed was the usefulness analysis. And we can just skip that because of the time constraints. So we'll just talk about the overall completeness and usefulness. So when we talk about the completeness here, here's where we actually had our most significant statistical findings. So overall completeness showed ChatGPT 4 at 2.05, Gemini virtually tied. It was a very small difference. It was at 2.04, and ChatGPT was significantly lower at 1.9. And so when we ran the ANOVA, the differences were statistically significant, as I just mentioned. And between the three LLMs, and the p-value was highly significant. It was 0.001. And after a post hoc, we identified two specific significant pairs, ChatGPT 3.5 versus 4, with a p-value of 0.001, and ChatGPT 3.5 versus Gemini, which was a little higher. So it was 0.003. So the clinical implication here, if we pay attention, it's very clear. It's that the newer, more advanced models, they provide significantly more thought and complete clinical information. That's the major takeaway from the results here. And this matters because the completeness affects the clinical decision making. All right, let's talk about the model performance. So just summarizing what we just discussed, the key findings in a clear performance hierarchy are very clear here. So ChatGPT takes first place, achieving the highest scores in accuracy, completeness, and usefulness. It generated the most comprehensive responses, and statistically speaking, it was superior in completeness only. Gemini came very close in second with near identical performance to ChatGPT 4. It was particularly excellent in differential diagnosis and showed a very strong clinical guideline adherence. So we also have another study that where we actually compared these models and their responses to the North American Spine Society guidelines, and we wanted to see how did they perform in relation to the guidelines. And then we have ChatGPT 3.5 ranked third, the weakest. It was adequate, but less complete. And it was because it showed higher variability in responses. And it was limited by its older training data. And over the time, even like the span of the last 2 years, these models have improved significantly. But here's what's crucial that all three models, they demonstrated clinically acceptable accuracy levels. We're not saying that 3.5 is unsafe, just that the newer models offer incremental improvements. And so the key takeaway here is that no model is perfect. Each has distinct limitations that clinicians just need to be aware of. And there are a lot of reasons for the differences. I just won't get into that. So it's because of the training data volume, knowledge cutoff dates, the context window sizes, and user-based feedback. So there are a lot of factors in play here. So we'll just talk about the clinical implications. So the potential benefits are real. They can provide rapid literature review assistance. They can support differential diagnosis generation. They can offer insights into rare cases. They can summarize treatment protocols. They can serve as educational tools. We personally use it in our university curriculum a lot. Helps us with lectures and other assignments, everything. And it can also help optimize a clinician's time, which is very valuable. And but the limitations are actually they're equally important. And the limitations have been discussed by all the previous speakers too. So we have AI hallucinations. It remains a serious problem. So the problem is that these systems they can fabricate references and the facts. And this was more significant back then. And they're working on this and it's improving, but it's still there. And the outputs, they're highly prompt dependent. So different phrasings will yield completely different responses. So they cannot assess, and plus there's the fact that the AI models, they cannot assess the patient's demeanor, general appearance, their socioeconomic status or context. They don't have that feel of when a patient walks in through the door and the physician takes the very first look. And at the same time, they also lack real-time patient interaction capabilities, and sometimes they miss considerations for advanced diagnostics. So, bottom line, AI must serve as an adjunct, not a replacement for clinical expertise, and that human oversight is non-negotiable in clinical settings. So it brings us to the last part regarding the safety considerations for patients. So that's paramount. So the major concerns we talked about fabrications, AI hallucinations, and uh, apart from this, there's also the risk of patients using these tools for self-diagnosis. So that's actually very serious problems. It's a serious problem because the patients, they have direct access to all of these models on their phones, and they might think of devising their own management plans without consulting physicians. They might use it to argue with the physicians without having a full context and background knowledge of everything. And it could lead to delayed diagnosis, inappropriate self-treatment, and the most serious problem would be missing out serious conditions. Um, so yeah, now just before I conclude, there are specific recommendations for different stakeholders. So from the point of view of a clinician, healthcare systems, and researchers. So for clinicians, LLMs would offer a great supplementary reference tool, and it will never be the primary decision maker, and you'll always have to verify the information independently, never trust it blindly, and remain aware of the hallucination risks and develop your prompt engineering skills to get better at responses. So this is very important. And maintain primary reliance on your own clinical judgment. So you're the doctor, you're not the AI. And for healthcare systems, what they essentially should do is implement structured evaluation protocols before deployment and establish governance frameworks for the use of AI, provide training on appropriate use, because it's a new skill set. And I think universities have started to implement this into the foundation year programs for medical students and students of other majors. And so updates on policies and as the technology evolves. And for researchers, this is the most important part, and that concerns us. Continuous, rigorous validation studies across different specialties, developing specialty-specific benchmarks, assessing real-world clinical outcomes, not just testing the performance, and then investigating advanced approaches like fine-tuning and RAG, so the retrieval augmented generation can actually help to provide more specific and guideline-based responses. The article was published. Any questions, just please let me know, and thank you all for listening.
Very beautiful. Thank you so much, Sayed. We do actually have some time for questions or reflections. We warmly invite all the audience or anyone interested to share your thoughts in the Q&A box or unmute yourself, please. Okay, so it doesn't seem that someone is gonna ask. I just wanted to probably point out a paper published by a team from KSU. That paper shows more qualitative failure mode and medical text-to-image output that can look plausible, yet but frequently fabricated, misleaded. It was more about heart, anatomical heart, and the same team, I joined them for the congenital heart disease, which is, I don't know if you have ever investigated this text-to-image output rather than just the text.
Text to image
Yeah.
output, I personally haven't worked with it, but we tried to use it for university slides and exam preparations and everything. It didn't perform very well.
Yeah. Yeah. Okay, so
Yeah.
based on your study, it seems that the ChatGPT-4 probably works best than the other models, right?
Yes.
Yeah. The other paper I mentioned, they actually investigated 3 or 4, I think, different generative AI models, including, of course, DALI, and DALI performed the worst. It would be very interesting to see how it does in neuro studies or in neuro education. Okay, so does anyone have a comment or a question to our esteemed speaker? Prof. Asma, I always get excited when you unmute yourself.
No, thank you. We're running out of time anyways. We need to move on to the
Okay.
speaker.
Okay.
So if
Brilliant.
anybody comes up has any other questions, you can meet
Yeah,
the speakers in the breakout rooms.
exactly. Okay,
Thank you
so
very much, dear doctors. It
Jazakallah khair.
was an honor and a pleasure.
Thank you so much, Sayed. Best of luck with your future and coming research interest.
Allah يجزاك.
Joining us next is our dear colleague, Dr. Lanud Saleh, an assistant professor in the Department of Radiological Sciences at King Saud University. Her work sits at the intersection of neuroimaging and brain changes, focusing, of course, on structural and functional neural connectivity and the neural plasticity that comes with learning. In other words, she studies how the brain rewires itself while the rest of us are still trying to rewire our Zoom audio. The floor is yours. Anu, take us in, please.
Assalamu alaikum. Hello, everyone. My name is Lanud Saleh, and today I'm gonna present our teamwork regarding to the impact of weight loss medications, but in this time from a neuroimaging point of view. I think most of you definitely heard about the weight loss medications, especially nowadays, which become a bit trendy. So in our research, we gonna investigate these weight loss medications effect on the brain in terms of function and structure. So as all of you know, obesity now has doubled worldwide, and it's not only effect on the body metabolism health, but it's also effect on the brain. So it can change the brain measures such as volume, cortical thickness. Also, it can alter reward, attentions, interoceptions networks. That's regarding to the food. How does the body interact, or the brain, sorry, interact with food? And finally, it can affect on the cognitive performance, which involves, for example, the memory and other cognitive measures. So the GLP drugs, or in other words, I think most of you heard about the drugs that used for mainly it's developed for type 2 diabetes, but they become trendy now, like for example Ozempic, Mounjaro, Saxenda. All these the GLP drugs, or the glucagon-like peptide receptor agonists, are basically made or developed for treating patient who has type 2 diabetes. It works by reduce the appetite and or craving, and increase the satiety. So that's why it can have very effective role in weight loss. So nowadays, it's not only used by diabetic, but also it's become popular through healthy overweight individuals with, and mostly, unfortunately, without medical supervision. So the knowledge gap, or most of the previous literature, were focused on the effect of these GLP drugs on a patient, for example, in pathological populations such as Alzheimer patient and other diseases. Lack of data focus on the healthy population, on their brain health and the cognitive performance. How does this GLP drugs affect on the brain and cognitive performance? Why this matter, or why this important? As I said, now become widely used by non-diabetic healthy individuals without any medical supervision, which increase our curiosity about the effects of these GLP drugs on the brain structure and functional connectivity, cognitive performance in healthy overweight adults. Our study involved 20, it's actually considered as pilot study. It involved 24 healthy overweight adults. Half of them, or 12 of them, were GLP users, and the other half match control. The including conditions should be their BMI. They are overweight, so their BMI more than or equal 27 kilos per square meter. We exclude any person who has neurological illness or psychiatric conditions, or he couldn't perform MRI, such as MRI indications. So the methodological steps involve all participants should complete the MRI brain imaging, structural and functional imaging, and also they perform cognitive assessment and psychological questionnaire, cognitive assessment for to assess their attention and memory, and the psychological questionnaire for depression symptoms. So in terms of MRI acquisitions and processing, as I mentioned before, we use two types of imaging: structural imaging and functional imaging. The structural imaging, T1, 3D T1 weighted MP range, and the functional imaging, we use resting state API. Different software were used. For example, for structural imaging, we use FreeServer. From its name, it's concerned about the service of the brain. It's analyze the image using the script of ReconAll, which involve many complex steps such as the skull stripping, normalization, registration, surface reconstructions, and parcellation to localize the changes in global brain atlas. And it gave us numerical data. This numerical data, it's about the brain measures or service measures, involve cortical thickness, service area, volume. And for functional imaging, we use to study the functional connectivity between several brain regions. We use MATLAB, Toolbox that works in MATLAB. And it's based on seed to voxel analysis. Here we use it for seed to voxel analysis, which means we specify the ROI, region of interest, and then we see in which area it does connect and how the nature of this connection, is it increase or decrease in connectivity. Also, we use GIF Toolbox to identify the independent brain networks through a group of ICA. And now I will explain them in further details. The main result here is the general idea of our result, and the next slides I will go through each of these results in details. In terms of structural result, we found thinner thickness in middle temporal gyrus and the right insula. In terms of area, large surface area in parietal, bilateral superior parietal loop, and in terms of volume, the subcortical volume, we found changes in the right caudate and right putamen. In terms of functional result, we found independent component analysis. We found changes in those main networks, which is the executive control network and default mode network. And in seed to voxel, we found some changes in orbital and motor areas connection or connectivity with other areas. That's consider as our region of interest here, which mainly responsible for specific tasks that may related to the food control or food attention and the visual aspect and from the body control aspect.
Dr. Al-Anoud, we are running out of time. 1 minute more, please. Jazakallah khair.
Only I have 1 minute.
1
Okay.
minute.
Okay. From behavioral perspective, so it's only in general we found less attention in people who take GLP drugs, less attention error, which means they are more focused, and they have low depression scores. So here it's only the thickness, it becomes thinner in drug users or GLP drug users, and this makes sense as this area is responsible for memory, language, visual perception, and sensory integrations. So it's a slow cognitive decline and reduce cortical atrophy. So usually in clinical trials, they found the effect of GLP drugs on this area is slow the cognitive decline and reduce cortical atrophy. But here it's in opposite side. We found thinner in those area. Maybe this is because different in study population. We use here healthy control. They use here patient study sample, and also the study design is different. Here we are cross-sectional. Their study is longitudinal. Maybe I go through the main findings. We also found the insula here is thinner, and this is because which is controlled. The insula part is responsible for emotional regulation and also the body state monitoring. So it can, and this match with our functional result in reducing the connectivity between insula and the precuneus area. So decreased connectivity in some areas that's responsible for for example, the reward value to food and the motor cortex. So these drugs is, as I told you before, it's reduced the appetite and increase the satiety, which means when we see food, we will not really affected. Even if we saw tasty food, this will not make us to eat more. Okay. Can I go through the final slide, if it is possible?
Okay, the final one. Thank you.
Yeah. So here, just to the main functional finding, these drugs can lower your default mood network and increase the control, which means you become more focused, stronger attention, and more control to your body. So you can control more to what you eat, and you can control your feeling more than the other overweight population. So in general, our study is a small sample size, and it's cross-sectional, not longitudinal, and we couldn't control the medications. So the medication type and dose were not controlled. So for future result, we may repeat this study with longitudinal design and more control through the medications in order to see what does these GLP drugs affect on healthy population. Also, the long-term effects, it's not show up now, but it's interesting to see it in the future work. Thank you, and sorry for taking more time.
Jazakallah khair, Dr. Anu. Thank you so much. All right, everyone. Breakout rooms are back open for each speaker. Think of it as the after party, but with better citations. We will have around 15 minutes. So 3:15, we have to close the breakout rooms to go for a break until 3:50. Best of luck with your breakout rooms, everyone. Please join the link that Dr. Asma has attached.